Maraho, Marakaza to our second NHI collaborative meeting. I want to thank all of you for being here. And before I go forward, my lovely assistant here wanted to say hello. This is my friend Poppy, and he has been trying to get into the computer to say hello to you. So I just wanted to share him with you. I really also want to thank our incredible Ihangane team, both for putting this meeting together and helping to facilitate it, as well as the work that they are doing on an ongoing basis. And I want to thank Angelique for helping us with our Road to Health game that you all will be playing later today. I especially want to thank our incredible advisors, Dr. Avit, Dr. Innocent, and Mubera. Dr. Avit's continuous support for our work has been very inspiring and motivating, so I always want to thank him in particular. So today we will be looking at the importance of accurate measurement and diagnosis of malnutrition as a follow-up from what you worked on the last meeting. We will also be focusing on the importance of appropriate HIV testing for HIV-exposed infants. In the United States, we have been able to decrease the risk of HIV transmission from mother to child from 35% risk in the early 1990s to less than 2% now. I am absolutely sure that Rwanda can be equally successful. I will be sharing how the United States did this, and Dr. Innocent has been very kind in preparing a presentation that will describe to you how this will be possible in Rwanda, following Rwanda's protocols that are based upon the latest available research and the most current information.
So today I wanted to share with you the United States experience of moving towards the elimination of mother-to-child HIV transmission. First, I wanted to share with you some of the background epidemiology in the United States of HIV amongst women and children. In 1985, 7% of the AIDS cases in the United States were amongst women. Unfortunately, that number has increased to 25% of AIDS cases in 2010. And as of December of 2010, there have been over 220,000 AIDS cases reported amongst women in the United States. But even though these numbers have increased, the number of HIV-positive infants that have been born each year has decreased from about 1,750 cases per year to approximately 143 cases per year as of 2010. And this graph shows you again that the dramatic decrease in the cases of HIV transmission amongst from mother to child from 1990, which again was approximately 1,750 cases each year, down to 143 cases per year as of 2010. So, how did the United States accomplish this? First, researchers focused on understanding the timing of HIV transmission from mother to child. Then researchers used this information to study potential interventions to prevent transmission. Currently, in the United States, we focus on early diagnosis of HIV in pregnant women and rapid utilization of antiretroviral medications. We also utilize our entire arsenal of interventions to prevent transmission. As you can see from this graph, transmission occurs throughout pregnancy, delivery, and postpartum periods. There is a 3% risk of transmission in earlier stages of pregnancy, a 7% risk later in pregnancy, 15% risk during labor and delivery, and 10% risk during breastfeeding. Over 25 years ago, researchers began focusing on a variety of interventions that could decrease transmission at each of these stages. Without any intervention, there is a 25 to 30% risk of mother-to-child transmission of HIV. In 1994, there was a groundbreaking study in which researchers provided AZT to HIV-positive pregnant women at 35 weeks of pregnancy and continued the AZT throughout labor and delivery. As long as these women did not breastfeed, the risk of HIV transmission to their babies decreased from 25 to 30% down to 12%. The following year, researchers announced that providing AZT to HIV-positive pregnant women earlier in pregnancy, such as less than 28 weeks, would decrease the transmission to 8%. This was the first time we had evidence that an intervention could prevent HIV transmission. The U.S. established a policy of AZT treatment for HIV-positive pregnant women and abstinence of breastfeeding. 5 years later, researchers determined that performing cesarean section prior to the onset of labor, in addition to AZT in pregnancy, could further decrease transmission to 4%. Unfortunately, cesarean sections did come with an increased risk of infection for the mother, and so must be weighed against the risks. In 2001, researchers discovered that using highly active antiretroviral medication beginning at 14 weeks of pregnancy could decrease the risk of transmission to less than 1%, even without performing cesarean sections. Our current United States policy is to provide antiretroviral therapy to all pregnant women and perform cesarean sections only if their viral loads are greater than 1,000 copies. Our national rate of HIV transmission from mother to child is now less than 2%. As you can see, the earlier the diagnosis, the faster we can provide treatment to the mother and more likely we are to be able to prevent the transmission of HIV from her to her child. So why isn't there zero transmission? Our goal is the elimination of mother-to-child transmission, and we have not been able to decrease the transmission rate to beyond less than 2% in the United States. This is because of missed opportunities, some of which are avoidable and some are not. For example, healthcare providers may forget to perform the HIV test during pregnancy. This is an avoidable situation. It is unfortunate and it is not uncommon. If the healthcare provider does not suspect the woman is at risk of HIV, they often do not believe the test is necessary. For this reason, it is recommended that every pregnant woman in the United States be tested for HIV at least one time during her pregnancy. Another reason that we have missed opportunities is related to the pregnant woman who may not be able to take antiretroviral medications for a variety of reasons. Unfortunately, we do see women who are unable to follow the guidelines to prevent mother-to-child transmission of HIV, particularly those women who suffer from mental illness or alcohol or drug abuse. We cannot always change this situation, but we can decrease the risk by using a combination of tools. For example, this year I was working with a young woman who is HIV positive and pregnant. She was using drugs, and I tried everything I could think of to help her quit her drug abuse. She tried to quit but was unsuccessful. She tried to take antiretroviral therapy, but her drug abuse got in the way. Luckily, we have a small community, and I was able to alert all of our local hospitals about her situation. When she arrived at the hospital to deliver her baby, the doctors knew exactly what to do. They gave Alice the AZT she needed. They performed a cesarean section because her viral load was greater than 1,000, and they gave her baby the AZT he needed. Luckily, the baby is HIV negative. Once an HIV-exposed infant has been born, there continues to be a risk of HIV transmission through breast milk. In the United States, HIV-positive women are advised not to breastfeed. This eliminates the 10 to 14% risk that is due to breast milk. In sub-Saharan Africa, however, the risk of death from malnutrition is greater than the risk of HIV transmission from breast milk. For this reason, women have been advised to breastfeed despite the increased risk of HIV transmission. But now there is hope. In 2011, an important study was reported from Lusaka, Zambia. In this study, it was found that providing 3 active antiretroviral medications during breastfeeding could decrease the risk of transmission through breast milk from 10 to 14% down to 3%. Upon closer analysis, 2 of the 6 mothers whose babies tested positive had stopped their antiretroviral medications without informing their healthcare providers. When adjusting the data to account for this, the risk of transmission decreased to 2% during breastfeeding. These studies have provided immense hope for a future free of mother-to-child HIV transmission. Unfortunately, even if we do everything perfectly as healthcare providers, there currently will continue to be some children who fall through the cracks and become HIV infected. It is extremely important that we identify these children early to prevent complications. This survival diagram shows the severe impact on the survival rates of children born in sub-Saharan Africa if they have untreated HIV infection. As you can see, uninfected children are shown in dotted lines, while HIV-positive children are shown in the continuous line. At 12 months of age, the cumulative percentage of death amongst HIV uninfected children was 3.6%, but it was 36% in HIV positive children. At 24 months, 5.5% of HIV uninfected children had died, but 54% of HIV infected children had died by 24 months of age. It is for this reason that we must diagnose and treat HIV-positive infants as quickly as possible so that we can reverse this awful trend. These survival rates are tragic. Luckily, there is something that we can do about it. Early diagnosis and treatment of HIV-positive infants saves lives. It's important to note that HIV-positive infants who are infected early, meaning during pregnancy or during the delivery, often have a much more severe course of disease. This is the reason it is so important to obtain an HIV PCR at 6 weeks of life. In sub-Saharan Africa, only 15% of HIV-exposed infants are tested for HIV in the first 2 months of life. And the majority of infected children less than 2 years of age die without having their HIV status definitively confirmed through virologic testing. This is the reason that we emphasize the importance of HIV testing protocols in our NHI children. In the United States, early initiation of antiretroviral therapy has dropped the mortality rate of children with HIV from 52% by their second birthday down to 7%. Dr. Innocent will share with you Rwanda's strategy for early identification and treatment of these HIV-positive infants. With strong adherence to Ministry of Health protocols, we believe that we can achieve success. This last slide is a reminder that we have 2 patients, the HIV-exposed infant and her mother. The risk of death for HIV-infected and uninfected children is halved if the mother stays alive.
So first, I really want to say congratulations on a job very well done. In the past 4 months, we have made amazing strides together. And we still have some work to do, but this is the way of life, and there's nothing unexpected about that. All of us at the Ihangane Project look very forward to working hand in hand with all of you to reach our goal of the elimination of HIV transmission from mother to child. I hope you have a wonderful day. I wish I was with you, and all of you take care. Thank you. Thank you. Have a wonderful day.
Thank you.
We're sending you love from America. Bye-bye. Marabeho.